Hey everyone, and welcome to part 1 of our Physical Therapy Coding and Billing Masterclass Explainer. I'm your host Harshal, and I am super excited you're here today. Look, whether you're a certified medical coder, a biller, a physical therapist, or running healthcare operations, you already know that physical therapy billing is incredibly complex. And let's be real, nothing strikes fear into our hearts quite like the word audit. But before we even think about touching a single CPT code, we have to lay the groundwork. Mastering the clinical foundations of physical therapy is absolutely the crucial first step to flawless coding. If you don't genuinely understand the clinical reality of what's happening in that therapy room, your coding won't accurately reflect the services rendered. And that right there, that opens the door to those dreaded audits and claim denials. So today, we're building a bulletproof foundation. Here is our roadmap for today's explainer. First, we'll dive into the why behind our clinical foundation. Then we'll cover the core clinical scope. Check out our target patient populations, break down functional justification, specifically ADLs versus IADLs, and wrap things up with a summary and our next steps. All right, let's jump right into section 1, the why behind our clinical foundation. Now, you're probably thinking, Harshal, I'm a coder, I'm a biller. Why do I need to understand clinicals before touching a single CPT code? Well, the answer is simple but profound. Mapping clinical realities to documentation is your absolute ultimate defense against claim denials and audits. You literally cannot code what you don't understand. When you actually grasp the clinical intent behind an intervention, you can immediately spot where the provider's documentation actually supports the medical necessity of the codes you're about to bill.
Moving right along to Section 2, Core Clinical Scope and Definition.
So what is physical therapy at its core? It's a tailored combination of exercises, stretches, and movements designed to enhance strength, flexibility, and mobility. And the absolute magic word here is tailored. Physical therapy is not just a generic out-of-the-box workout routine you find online. It's a highly customized clinical intervention. When an auditor looks at a chart, they aren't looking for some cookie-cutter exercise sheet, right? They're looking for a customized plan of care designed specifically to restore that unique patient's physical function. Building on that definition, let's talk about the clinical objectives. PT aims to aid recovery after a surgery or an injury, manage symptoms of conditions that affect mobility, provide highly effective pain management, reduce scar tissue, and, ultimately, restore overall function and quality of life. For us as coders and billers, the crucial point is this. These specific objectives represent the exact outcomes auditors are hunting for in a clinical chart. If the documentation doesn't clearly show that the therapist is actively working toward one or more of these specific goals, the medical necessity of that service is going to be heavily scrutinized.
Which brings us to Section 3, Target Patient Populations.
Physical therapy isn't just for one type of person. The demographic spread is massive. Just think about who walks through the clinic doors every day. If it's a weekend warrior or a serious athlete, your brain should be hunting the chart for clinical indications like sprains, strains, tendinitis, or dislocations. But if it's a remote worker who's glued to a desk all day, you're expecting to see notes on ergonomics, neck and back pain, sciatica, or carpal tunnel syndrome. Chronic pain patients bring a completely different clinical picture entirely, usually presenting with fibromyalgia, arthritis, or severe lower back pain. And for those post-surgical or trauma patients, the acute focus is going to be heavily on scar tissue reduction, pain management, and urgently restoring that functional mobility.
Now contrast that office worker with a geriatric patient whose focus is purely on fall prevention, balance, coordination, and endurance. It's a totally different world. Then you have neurological disorders, where the therapist is deep into stroke recovery, reducing spasticity and improving fine motor control. And we haven't even touched on pediatrics, dealing with developmental delays and muscle tone, or pre- and postnatal patients needing targeted core and pelvic floor rehab, plus respiratory care to enhance breathing. The massive takeaway here? A cookie-cutter approach to billing will absolutely fail. The clinical picture from a pediatric patient to a geriatric one is wildly different, and your documentation has to reflect the unique needs of that precise patient group. All right, Section 4, Functional Justification. ADLs versus IADLs. This is honestly the absolute climax of our explainer. This is where clinical theory meets payable claims. We need to draw a very clear, definitive line in the sand right now between ADLs and IADLs. ADLs, or activities of daily living, are the basic, fundamental tasks required for personal self-care and hygiene. Think of basic survival at home. IADLs, or instrumental activities of daily living, on the other hand, are the complex, higher-level tasks required for independent community living. Why does this distinction matter so much? Because physical therapy aims to restore a patient's ability to perform these exact specific activities.
Let's break down the ADLs first.
These include bathing, dental hygiene, toileting, eating, dressing, and transfer and mobility, like just safely moving from the bedroom to the living room couch. These are strict fundamental survival activities. Deficits in any of these areas represent severe functional limitations. When a therapist documents that a patient cannot safely transfer from a bed to a chair, that strongly, undeniably justifies the medical necessity for physical therapy.
Now, let's shift gears to the instrumental activities, the IADLs. These include things like cooking and house cleaning, managing medication and finances, doing laundry and shopping, and handling communication and transit. These are the intricate tasks required to function independently in society. An inability to perform these complex tasks also establishes a vital medical necessity for rehabilitation. For instance, if a severe wrist injury prevents a patient from cooking meals, paying bills, or driving to work, that functional deficit is exactly what needs to be highlighted in the evaluation to justify therapy to the pair.
Okay, listen closely because this is the golden rule of PT documentation. You know that horrible sinking feeling when an audit letter arrives? Yeah, vague charting is almost always the culprit. Merely stating declined in function in a chart is completely insufficient. It will fail an audit every single time. The evaluation must provide an objective description of functional changes. Deficits in the specific ADLs and IADLs we just discussed must be clearly charted. This objective functional data is the absolute cornerstone of proving medical necessity. Vague notes get denied, specific objective ADL and IADL deficits get approved and validate your claim.
And that brings us to Section 5, Summary and Next Steps.
Let's lock in this foundational knowledge before we go. First, clinical comprehension is your ultimate shield against claim denials. Second, PT targets incredibly diverse populations, requiring tailored documentation for everyone from high-performance athletes to neurology patients. Third, medical necessity relies entirely on charting objective functional deficits. And finally, accurately documenting those specific ADLs and IADLs is exactly what undeniably justifies the initiation of skilled therapy in the eyes of a pair. You guys now have the foundational clinical mindset required for flawless coding.
Now that our foundation is bulletproof, you won't want to miss what is coming up next. In Part 2 of our masterclass, we are diving deep into the highly anticipated technical CPT coding. We'll be unpacking supervised modalities, specifically looking at the nuances of billing hot and cold packs under CPT 97010 and mechanical traction under CPT 97012. We're going to take all this clinical theory we just learned and apply it directly to the codes. Before you go, I want to leave you with a quick question to think about. If an auditor pulled your last 5 PT claims right now, does the functional documentation truly justify the therapy, or are you at risk? Seriously, think about it. Make sure you subscribe and stay tuned for our next module so you can continue building your expertise and protecting your clinic's revenue. Thank you so much for joining me today. Until next time, Decode Healthcare with Harshal.